We want to start our session. Have a seat, please. Okay. May I invite Dr. Khaled Salaymenh. Dr. Khalid is a senior consultant pediatric cardiologist. He will talk to us about managing acute post-neonatal cardiac surgery problems. Cardiologist perspective.
شكرا دكتور عوني وشكرا يا دكتور علي على دعوتي لإعطاء المحاضرة. أول مرة بتشوفوني ببدلة يمكن من 10 سنين، فكله سكرابز. قلت أنا أغير حتى يمكن في البعض ما يعرفني. وين السلايدات يا بنيي؟ يلا.
يعطيك العافية.
تمام. الحقيقة هذا موضوع مهم وأنا بحب أحكي فيه لأنه مش الكل بيهتم في البوست أب مانجمنت، وأنا كنت محظوظ وبيعرف دكتور يوسف لما كنا في التريننج. مش عم تمشي هاي يا أخي العزيز، وين راحت هاي؟ أوكي. تمام. When I was a fellow, we were taught that there were 5 branches of pediatric cardiology: echo, interventional, electrophysiology, cardiac intensive care, and molecular cardiology. لما بلشت أخلص training بالlate 90s, other subspecialties came up: heart failure, transplant, MRI, adults with congenital heart disease, and cardiac oncology. Why am I saying that? Because I see a lot of newer generation people coming, and they need to know that the branches of cardiology are not only to put in either stents or devices or valves. بداش يزعل مني دكتور زياد، ولكن there are other branches وإحنا في البلد بحاجة هاي البرانشز بصراحة. We need MRI specialists, we need intensivists, we need heart failure specialists, we need people specialized in adults with congenital heart disease. الصور اللي على اليمين بيعرفهم دكتور يوسف، هم اللي علمونا بالبيدياتريك كاردياك ICU. They were people trained with triple boards. ديفيد نيلسون اللي على الشمال وديفيد شوارتز على اليمين. They were trained in pediatrics, then pediatric cardiology, then pediatric intensive care, and they were the ones who taught us how to do pediatric cardiac ICU care. The overview, we will focus on the first 7 to 10 days post-cardiac surgery in neonates. And our objective is to identify common problems, systematic evaluation, and rapid intervention. And our approach is physiology driven. وهذا أهم شيء. البيدياتريك كارديولوجيست الانتنسيفست بحاجة إنه يفهم الفيزيولوجي. Our colleague البيدياتريشن, general pediatrician, or the general pediatric intensivist lacks this perspective initially. ولكن بين الhelp البيدياتريك cardiologist with the pediatric intensivist or someone trained in both will grasp the physiology of the congenital and the pathophysiology of the congenital heart disease and of the surgery, and that leads to multidisciplinary and echo-guided management. And then we will have one case at the end. There are some unique neonatal considerations that are particular to the first 30 or 40, 50 days of life. And this is the immature myocardium with poor compliance and limited contractile reserve. There is extremely reactive pulmonary vascular reactivity, and the risk of pulmonary hypertensive crisis is very high. Your patient will be sliding beautifully, and then he can go with any trigger to develop a pulmonary vascular or pulmonary hypertensive crisis, and this is deadly. There is a high metabolic demand with limited reserves, and I will give you an example. Those kids could go to sugar of 30 within 20 or 30 minutes after surgery, and nobody is paying attention because their liver reserve is really very small, and you have to watch for that very carefully. Small blood volume, so rapid deterioration with bleeding or dehydration. Okay, so the first problem I'm going to talk about is low cardiac output syndrome, and this is the most common thing that could happen following cardiac surgery in the neonate. And what does it mean is that the heart is unable to meet the metabolic demand of the baby, and the causes are several. Number one is myocardial dysfunction. Number two, residual lesions or tamponade, hypovolemia, or sepsis. These are critical to watch for and then probably manage them with rapid interventions. And I put them in red because they are extremely critical. How to recognize them: tachycardic. So your patient, when he becomes tachycardic, you have to understand why. طبعا our tachycardia in pediatric cardiology is different than the adult cardiologist. 180, 190, or 200 is our tachycardia. 120, 130 is not our tachycardia. Cool extremities, and I teach our nurses in our ICU at Al-Khalidi to feel the patient. When I tell them how is the skin, is the patient cold or not, they think that I need the temperature. I don't need the temperature of the baby. I need to know, is the baby cool or warm? And there is a huge difference between both. Low urine output, the number one question we keep asking the surgeon and I, or the intensivist in the ICU, is what is your urine output? And it should be above 1 cc per kilo per hour. If it goes below that, you have to question why. And then high lactate, and you saw that our Italian guest speaker from San Donato insisted on getting lactate levels, and we do, and also low mixed venous sats, and those are the two most important parameters that people use nowadays in ICUs for neonatal cardiac surgery. How would you manage low cardiac output syndrome? Optimize preload. Keep your CVP around 10 and decrease your afterload if your afterload is high. And inotropes, the two most important inotropes in neonatal cardiac surgery are adrenaline and milrinone. The two medications that should not be out of your ICU for neonatal cardiac surgery are prostaglandin and milrinone. In our hospital, they start milrinone on the pump, and the patient come to our ICU on a milrinone drip in 90% of our surgeries, except for ASDs or something really simple. Correct acidosis with bicarb if needed, and maintain oxygen delivery. Make sure your hemoglobin is high, and consider mechanical support ECMO, and I wrote it in red because we don't have ECMO in Jordan. And I'm writing to you the things that I think we need to make an impact and change for the future of our neonatal cardiac surgery in this country. The timing of low cardiac output syndrome is critical. So there are several factors that lead to the low cardiac output syndrome. Number one is coming off pump. The myocardium recovers, and it's usually a stunned myocardium, and happens. Edema of your myocardium happens, and there are some release of the systemic inflammatory mediators that can lead to the low cardiac output syndrome. The peak happens between 12 and 24 hours, and it starts between 6 to 12 hours. So what does that mean? If you are out of surgery by noon, expect that by midnight or 3 or 4 o'clock in the morning, this is the peak when your patient deteriorates. And Dr. Youssef remembers very well when we were fellows at Cincinnati Children's, you were asked to go and round on your patient at 2 or 3 or 4 o'clock in the morning to make sure that the patient does not deteriorate and you're not observing all the vitals of your patient. And then usually 24 to 48 hours, your patients start recovering, and then after that, you are out of the woods. Okay, now the second problem is hypoxia or hypoxemia and desaturation. Usually the reasons are either cardiac, pulmonary hypertension, or non-cardiac, like atelectasis lungs, don't forget those, shunt or obstruction. And check QPQS, and I will put a slide for you, and I will give you my perspective of how to watch for QPQS, because this is the number one issue to monitor for neonatal cardiac surgery, especially in single ventricles. Optimize ventilation, oxygenation, and sedation, especially sedation. This is, in my view, the most important slide of the talk, which is how to assess QPQS. And I'll explain it to you, if you don't mind, in Arabic, but also use some English in the middle. إحنا بالعادة pulmonary circulation, if you send 1 liter to your pulmonary circulation, you have to send 1 liter to your systemic circulation. So the QPQS is 1-to-1, meaning that the more you send, if you have a congenital heart disease, there is a difference in perspective. You, as a human being, there is a separation between the systemic and the pulmonary circulation. However, in single ventricles, which are the most critical, those patients are connected via a shunt. So if your pulmonary circulation gets too much blood, that means that your O2 saturation will go up, but sadly, you steal blood from your systemic circulation, so that means lower blood pressure, lower urine output, and those patients die of shock. On the other hand, if you get too little pulmonary blood flow, there is less pulmonary blood flow. That means your baby is blue, but your blood pressure is good and your urine output is good. So how can you manage? If you have a pulmonary over-circulation, too much blood going to the lungs, you have a pink baby, poor perfusion, and acidosis, and those patients die. So you need to lower your FiO2. And that I had a hard time convincing general pediatricians of doing, because we have to accept SATs in the mid-70s. We don't like SATs for single ventricles to be 85 or 90, because that means that you are stealing from your systemic circulation. Don't forget, your pulmonary circulation and your systemic circulation are connected, so you have to make sure they are balanced. The best O2 saturation to balance your patients is 75-80. Once you reach 85, we get scared. So drop your FiO2, increase your CO2. Don't forget that CO2 is a good vasoconstrictor, pulmonary vasoconstrictor, and oxygen is a pulmonary vasodilator. These things are very important for you to manage your patients. Increase PEEP. Why PEEP? Because if you increase PEEP, you increase your intrathoracic pressure. You're asking blood not to come to your lungs. So increasing your PEEP to 5, 6, or 7 can lower your pulmonary blood flow. And of course, decrease afterload. Why? Because if you dilate your aorta, you're asking blood to go through your aorta and not your pulmonary circulation. Of course, the opposite happens if you have a systemic dominance. Your QPQS less than 1 means more blood going to your systemic circulation. That means your O2 saturation is low. You have to increase the FiO2, hyperventilate a little bit, decrease your PEEP, and increase your afterload. Why increase your afterload? If you increase your systemic pressure, you push more blood through the shunt, and that increases your pulmonary blood flow. So you have to maintain a balance, a QPQS of 1:1. I think this is an important thing to understand for single ventricle management. The number 3 problem is arrhythmias, and they are really common. The most common one that we used to see was jet. AV block is not uncommon. Atrial flutter is rare. VT can happen, especially after arterial switches, because it involves the coronary circulation. And the causes are either surgical trauma to the conduction system or electrolyte imbalance. So always check your calcium, magnesium, and your electrolytes. Ischemia can happen, especially when it involves the coronaries, and hypoxia in general can lead to arrhythmias. Management. يمكن دكتور يوسف بتذكر we used to cool our patients ذكر cooling blankets for jet and also أنا لأنه ما عندي cooling blanket في الخالدي I use a fan فكانوا يجوا رايلي children يقولوا لي we use the fan therapy. We optimize sedation and minimize catecholamines. I think the number one thing you can do to minimize catecholamines is just go down on your dopamine. It's the number one culprit for jet is dopamine, so try to avoid dopamine if your blood pressure is good. Your friends for management of arrhythmia, especially jet, is amiodarone or procainamide. I have never used procainamide, but cordarone is really a good friend. Temporary pacing, if indicated, I have never used temporary pacing, but Tim Nylans used to do that a lot. I just want to give the students examples of jet. This is junction ectopic tachycardia when there are no P waves and there is an AV dissociation. It's a fast heart rate. Usually it's around 170, 180, 190. You have to get a 12-lead ECG. And please, I always urge the new grads not to rely on the rhythm strip, because the rhythm strip can deceive you and you might be able to see P wave. There is a huge difference between sinus tachycardia and junctional ectopic tachycardia. This is another example that I chose the best for the students to always remember atrial flutter. I don't see it as much, but it can happen. And this one, you can treat it with amiodarone, but you need cardioversion, 1 to 2 joules per kilo. And you have to be courageous in using your DC shock and don't be scared or someone to intimidate you. Number 4 problem, which is really common, which is the pulmonary hypertensive crisis. If this happens, you are in trouble, but you need to have your backup plan of what are the steps to take. Remember, there are triggers for pulmonary hypertensive crisis. Number one, hypoxia. Pulmonary artery pressures, they do not like hypoxia, they love oxygen. Acidosis is the number two culprit. Pain, when those patients get triggered with pain and they scream, they can go into a pulmonary hypertensive crisis. And suctioning. So if you ask your team to care for a shunt patient, don't ask them to to suction them very aggressively. They need to be suctioned, but if you suction them aggressively, you might induce them into a pulmonary hypertensive crisis and they might die. And I've seen that happen to us when I was a fellow, even in our ICUs at Al-Khalidi. The mechanism is simple. You increase your pulmonary vascular resistance, you have RV failure, your RV cannot function, and you have a decrease in your cardiac output. How do you manage? The number one thing you do is increase your FiO2 to 100. Be jurious, fine, go up to 100. You are not a neonatologist. ما يخوفوكم من neonatologists. Neonatologists, they get scared of oxygen. We don't get scared of oxygen. Oxygen is our friend when we need oxygen. And of course, correct acidosis. Deep sedation. Of course, inhaled nitric oxide, and I put it here in red because we don't have it available in the majority of the hospitals. Sadly, we have nitric oxide at Al-Khalidi, but over the past 3 years, we have a broken item that Al-Khalidi, they cannot replace it. But nitric oxide is essential for neonatal cardiac surgery. Sildenafil can be used. However, my best friend in these circumstances is milrinone. Always remember that you need to maintain systemic blood pressure higher than your pulmonary artery pressure. Of course, ECMO is for refractory cases, and I put it in red again so that the newer generation know that we need ECMO for our patients. Number 5 problems are the residual lesions and mechanical complications. There are residual VSDs, LVOT obstruction, especially in complex congenital heart disease like Norwood's, conduit stenosis, like for someone who had a truncus arteriosus or tamponade. The clues are the patient is persistently unstable and significantly acidotic with high inotropic need. And you need to do an urgent echo. You have to have always an echo in your ICUs to monitor the situation of your patient. And sometimes you have to intervene either surgically or in the cath lab. Bleeding and tamponade, this is one of my favorite things to talk about. How do you manage or how do you rate that your patient is bleeding or not bleeding? If your bleeding is less than 5 cc's per kilo per hour, then you know your patient is not bleeding. When you start reaching 5 cc's per kilo per hour, you start wondering, are we missing something? If you reach 10 cc's per kilo per hour, call your surgeon and tell him this is what we have. Because if you wait further than that, you go into a DIC situation, your kidneys get knocked down, your liver gets hit, and also your brain, and your patient becomes acidotic. So the causes are either surgical bleeding, coagulopathy, platelet dysfunction, bypass effects, also dilution or liver immaturity of the neonates. How do you see that? For a tamponade, you see a rising CVP, but also a falling blood pressure. This is a good combination to remember with reduced chest tube. You had a chest tube that was functioning, and then all of a sudden your chest tube drainage is going down. You have to wonder, where is this blood going? المريض لازم يطلع بالchest tube. إذا بطل يطلع chest tube بدك تدور. Chest X-ray, echo, you have to find out. Sometimes the abdomen, by the way, they might have a GI bleed, but this is not the subject of our talk. But make sure you get a chest X-ray, make sure there is no hemothorax or there is no tamponade. Now, the management used TEG-guided transfusion, and I'll have a slide for this. This is something recent. I heard about it yesterday, and I talked to the guys back at Indianapolis where they come and help us out. This is a standard point of care in the anesthesia downstairs in the operating room, and I'll give you a slide about that. Replace blood products. Now, forget platelets, FFP, and cryo, and give protamine if you think your ACT is high. And surgical re-exploration, and don't hesitate to call your surgeon and tell him, hey, I have a problem, because he's your backup. He needs to come open and help you out with your bleeding. The TEG-guided transfusion strategy is a test simple bedside that we don't have in Jordan. They have it in the US or other big centers in Europe. However, it's not a standard of care in their ICUs, but it's a test that people are introducing more and more to the ICUs. It's a standard of care in the operating rooms. It tailors what kind of blood products you're giving to your patient according to the need. There are several things that you can see here that I have never done, but I thought I would put it in front of you because we need to introduce this to our ICUs or to our anesthesia. And by the way, the team from Riley answered me this morning that they are doing an FDA studies for the FDA to approve this for children. So the benefit of the tech-guided transfusion strategy is to reduce unnecessary transfusions and also let the intensivist know what kind of blood products you have to give according to the results. Non-cardiac complications, don't underestimate the non-cardiac. You have to understand cardiac physiology and pathophysiology and how to manage them, but also don't be blind of what could happen. Atelectasis is your number one enemy, effusions on both lungs or pneumonia, infections of the lung. And kidneys are extremely sensitive organs to the pump, to lower blood pressure. So you might have rising creatinine or a rising BUN on your neonates after surgery. So you might do peritoneal dialysis or early CRRT if needed. Infectious line sepsis and mediastinitis. I have to say that we have had a huge problem with line sepsis at Al-Khalidi a long time ago. However, now we are trying to avoid femoral lines because, as you can imagine, the femoral area is very close to the diaper area, and those can get a gram-negative sepsis, and they are devastating. So a bit older than 2-3 months, they try to put under ultrasound an IJ and avoid femoral. Still neonates, we put femoral, but we are very keen to remove the central line next or the third day after surgery. And as you can imagine, your electrolytes and glucose stability are extremely important following those surgeries. The integrated team approach, the post-op management is not single-handed by one person, and that's what caused me to love talking to you, that this should be a team approach. You have to watch the patient very carefully, minute by minute, and this has to be done by the cardiologist, by the surgeon, by the intensivist, if available, and also the nurses. So it takes so much time to train your nurses how to watch your patient. ما تنسوا إنه هذا وزنه 3 كيلو طالع من سويتش أو 3 كيلو حاطط شنط، ما بيعرفوا فلازم تيجي وتوقف. فإحنا بصراحة أنا شخصياً كل يوم الصبح بنيجي لما يكون عندنا سيرجري باجي للتيم مين بده يسلم مريضي والله فلان ترى بده ينعمل له 1 2 3 we look for 1 2 3 4 expect these problems and you have to watch the patient accordingly, otherwise the nurses wouldn't know, the pediatrician hospitalist doesn't know unless you explain to them, and you and the surgeon have to be in touch all the time. And of course, use the standardized post-op instability pathways. You have to have a backup plan for every possible problem that could happen, not to think of the problem and the solution right when it happens. You have to be prepared. Cardiac surgery and post-op management as the interventions, and you have to be prepared for the problems. Ziad, you always mentioned about, you have to have the equipment ready because if these things happen, you have to do this. In ICUs, these are things that you have to keep in mind. And clear escalation criteria, and you have to have ECMO, which sadly we don't have. Think about it for the future, please. This is a case, a 7-day-old neonate, and this is a case scenario that I made up after a total anomalous pulmonary venous connection. شو اللي طلع لي هذا يا شباب؟ شكرا، شيل هاي لو سمحت. Of course, the day number 1 after surgery, there is a progressive desaturation, tachycardia, metabolic acidosis. The patient on a ventilator with FI2 of 80%, low dose dopamine, the vitals heart rate of 180, which is elevated, blood pressure on the lowish side, lactate is higher than usual, urine output is 0.5, so that means there is a problem. You get a chest X-ray with pulmonary edema, with the echo, with good biventricular systolic function, with mild RV, pressure elevation, and no venous obstruction. So what would you do? You have to immediate stabilization, increase your FiO2 because your O2 saturation is low temporarily, ensure deep sedation and paralysis, keep airway, ventilation, and tube position. So always get a chest X-ray. And then بقول للhospitalist, if you have a problem and you get an ABG and a chest X-ray immediately, I would not fault you. ما بحاسبك ولا بقول لك ليش. لأنه these are the safest, simplest things you can do to get to know your patient. And then hemodynamic optimization, you give a bolus of fluid of 10 cc's per kilo. You can use normal saline, you can use albumin. I like fresh frozen plasma and sometimes blood if your hemoglobin is marginal. Start milrinone. Remember always neonatal cardiac surgery They love milrinone. It's a phosphodiesterase inhibitor. It helps improve diastolic function, and also it helps drop your pulmonary artery pressure. It's an extremely friendly medication if your blood pressure is adequate. Escalate QP-AQS balance. Your O2 is low sats, and your low blood pressure, you have a systemic still likely. If you have pulmonary hypertension, hyperventilate, increase your FiO2, drop your PEEP, and maintain afterload. And if you address pulmonary hypertension, inhaled nitric oxide is your number one option if you have it. If you don't have it, urge your hospitals, and I am not kidding. Everybody should ask their hospital that does cardiac surgery to bring nitric oxide. This is not a joke. Monitor and reassess serial ABGs, lactate, urine output, and repeat echo, and escalate if ECMO is, if your patient is refractory. These are my last slides, but I just want to elude your attention that there is a Pediatric Cardiac Intensive Care Society started in 2003, and I'm a member with them. I have attended several of their meetings. This is the website. They are amazing. They put protocols. It's a huge group of people that I urge the newer generation to know them. So the key takeaways are: anticipate lesion-specific complications. If you have an arterial switch, imagine what are the complications of an arterial switch. If you have a shunt patient, think of what are the shunt complications. So each specific lesion has specific complications. You have to be aware. Treat physiology, not just numbers. And I tell the newer generation, we are doctors. We are not number doctors. We are clinicians. We are not number doctors. These are extremely important. Act early. Time is myocardium, and teamwork saves lives. I want to thank the Al Khalid ICU team because they have been amazing to support me. And these are from the Pediatric Cardiac Intensive Care Guidelines, the STS guidelines, and also the European guidelines. Just to let the newer generation students know that we have the 20th Annual Pediatric Review Conference on the 2nd and 3rd of April next year, inshallah, Bil Royal. There are 46 lectures in pediatrics and pediatric subspecialties, 12 speakers from the US, and we have, as Dr. Ferrari said, we have an AI and pediatric symposium. I use AI in my practice daily to talk and ask about specific syndromes associated with diseases. They come to my practice. I just ask ChatGPT, what do you think of this? What do you think? So we have an AI and pediatric symposium, inshallah. وشكرا لكم.
Thank you, Dr. Khalid, for this comprehensive and useful talk. We let the questions to the end of the session. May I invite Dr. Tanya Alhaj Hassan. She will talk to us about renal function preservation post-cardiac surgery.
السلام عليكم، كيف حالكم؟ أول إشي أنا بعرف إنه نحن كتير متأخرين، تقريبا نص ساعة، فعندي two presentations ورا بعض. بحاول شوي أقصرهم عشان تروحوا بالوقت الصح، ولأنه دكتور كوتزا بستنانا أظن أونلاين. he's the last speaker remotely. إذا عم بتفكروا مين هاي، معكم حق، أنا ما كنت أشتغل هون، صار لي 23 سنة مغتربة، جديد رجعت على الأردن. pediatric intensivist، بس لسه ما بشتغل clinically في الأردن. رح أحكي معكم عن two topics. الtopic الأول اللي هو renal function preservation after cardiac surgery. والtopic الثاني هو ICU delirium in the post-op care of cardiac patients. تمام، خلينا نبلش. I'm going to present in English. I'm sorry. I know this is an Arab country, and in an ideal decolonized world, we would be doing everything in Arabic. But hey, this is the world we live in. So this picture is not random. There's a reason there are a lot of organs in this picture, and I'm focusing particularly on the heart and the kidneys. It's because the kidney receives about 20 to 25% of resting cardiac output, and because all of these organs talk to each other. Damage to the kidney affects all the other organs, and equally, protective measures for the kidneys protect all the other organs. So I'm going to start out by declaring no conflicts of interest. A bit of an introduction about this topic. So pediatric cardiac surgery, particularly cardiopulmonary bypass, poses a significant risk to renal function. And it's marked by a rapid decline in the glomerular filtration rate, and the accumulation of nitrogenous waste products like urea and creatinine. The incidence is actually a lot higher than you expect. A long time ago, it was around like 5 to 8% incidence of kidney injury after cardiac surgery in children. But at the time, they were focusing on very late, the diagnostics only recognized late stages of kidney injury. Now, with the evolution of our ability to diagnose acute kidney injury, and with some consensus criteria that I'll talk about in a little bit, the Kidney Disease Improving Global Outcomes, or KDIGO guidelines, or neonatal KDIGO guidelines, definitions, mean we're better able to identify acute kidney injury. And we're also expanding our ability to treat congenital cardiac disease. So there are lesions that we wouldn't have treated a long time ago that we treat now, and that maybe are more complicated to treat and more likely to give you acute kidney injury, like hypoplastic heart syndrome, for example. So because of these developments, the incidence has also risen. Now the incidence is anywhere between about 10% and 40-some% for acute kidney injury after cardiac surgery. And I'm going to use that acronym going forward, the Cardiac Surgery Associated Acute Kidney Injury, CS-AKI. The rates are particularly high in neonates, children under 2, or any infant undergoing biventricular cardiac repair. Preservation, it is a very serious complication because it has both short-term and long-term complications. It increases morbidity, hospital stay, mortality rates. It's implicated in pulmonary edema, in fluid overload, in diastolic cardiac dysfunction. And then there are long-term impacts, for example, repeat episodes of cardiac surgery-associated AKI. If you have like a staged procedure and the child gets AKI with each episode, are associated with lower cognitive, motor, and language scores in long-term follow-up. Just a quick slide about pathophysiology. Hyperperfusion and ischemia play the bigger impact. That's the biggest impact. That's usually during a cardiopulmonary bypass. Renal perfusion might be compromised, especially anytime you have low flow states or hypotension. Inflammation, which is often triggered by cardiopulmonary bypass, that's the SIRS response that you get, as well as hemolysis releasing free hemoglobin, which is nephrotoxic, can damage the kidneys. And then from reperfusion injury, you can end up with oxidative stress and tubular damage as a consequence of that. And finally, we use a lot of nephrotoxic medications. Some we can avoid, some we can't, including inotropes, antibiotics like aminoglycosides, and contrast agents. And all of these might worsen renal outcome. So I like to think of it as preoperative, intraoperative, and postoperative factors. Children in the ICU are at very high risk of developing AKI because of the confluence of these three things. This is an image taken from a review that I cite at the end by Morgan et al. So preoperative, prior to undergoing cardiac surgery, patients are subject to a number of insults. Some patients have decreased renal reserve as a consequence of their age, as a consequence of cardiorenal syndromes, as a consequence of cyanotic heart disease, genetic syndromes. They may also have intravascular volume depletion prior to surgery. And then intraoperative, we talked about some of the pathophysiology behind that, but it's usually mediated by aortic cross-clamping, periods of circulatory arrest, hemodilution, periods of arterial blood flow, decreased arterial blood flow, and then we talked about hemolysis with the release of hemoglobin, inflammation, oxidative stress. All of these things will impact your endothelial function. And then post-operative, cardiac dysfunction is a very big one, and I'm going to talk a little bit about the same things that Dr. Salaymeh talked about. I'll just keep it really brief since he already covered a lot of the things to do with low cardiac output syndrome. Hypoxemia, intravascular volume depletion, all of these things can compromise renal recovery, as well as the nephrotoxin exposure from the medications we give. So if you think in summary of the sort of the factors that, or risk factors that you need to think about with cardiac surgery related AKI, decreased age, pre-existing renal dysfunction, so things to think about as the child is coming, or even before, a lot of you are surgeons, so even before that, as you're assessing how vulnerable your child is going to be in the surgery or how vulnerable their kidneys are going to be, think about their age, whether they have any prerenal dysfunction, try longer cardiopulmonary bypass times, more than an hour and a half, deep hypoxemic circulatory arrest, any low cardiac output post-operatively, and that's where people like me come in, trying to avoid any post-operative insults. Complex surgeries like single ventricles make you more likely to develop CSAKI, and then we talked about nephrotoxic medications. So what risk assessment or tools do you use to decide if a child is at high risk of AKI? Can I just ask? I know everybody's starting to sleep, it's been a long day. What do you use? What diagnostic tools would you use for AKI? BUN and creatinine. Okay, good. So let's start with creatinine. That's the traditional marker that's used for renal function. Do you guys know when it rises approximately? Takes a long time. It doesn't rise until the GFR, you lose about 50% of your GFR. So it's a very late stage. Also, a lot of your patients have hemodilution, they're fluid overloaded, and so that's gonna make you underdiagnose AKI using creatinine as a marker. So even though it's traditionally the marker that's used, it's not a very good marker to detect early signs of AKI. Any other markers? Urine output, very good. Urine output, probably the second most common used. And urine output often may not be present to the extent you would expect, or decreased urine output, because, I'm sorry, I just moved my, usually we qualify it as less than 0.5 mLs per kilo per hour over the first several hours. You may not see urine output that's that low because the child is already on a decent amount of diuretics, so iatrogenic diuresis. So again, you might underdiagnose your AKI if you're just relying on your urine output. Urine analysis. What are you going to see in your urine analysis? So ideally, you would have a biomarker, right? The way we have a troponin, for example, for damage. So you don't want the biomarker that tells you the renal function has decreased by 50%. You want the biomarker that tells you the kidneys are injured, and way before the renal function starts decreasing, something like a troponin, but for kidneys. We don't have that in pediatrics. In fact, we don't really have that in adults either, but there are a lot more studies that are done in adults. So creatinine will lag behind, sometimes about 24 hours. You want an index or a marker of injury, not an index of function. KIM is kidney injury molecule 1, kidney injury molecule 1, for example, plays an important role in cleaning up the products of apoptosis. So that's one molecule that's being studied amongst many others. Unfortunately, we don't have data on those in children. There is one thing that I'm going to suggest, and I suggest you also go read about it because it's not that frequently used, but is very promising. It's responsiveness to loop diuretics. So impaired responsiveness to loop diuretics has been proposed as an early diagnostic marker of AKI. It's a strong predictor of adverse outcomes in pediatric heart failure. And they suggest this furosemide stress test, where they give a standard diuretic challenge with urine output assessed at 2 and 6 hours, and a lack of responsiveness is actually, in the studies they've done, a good predictor of subsequent AKI, and an earlier predictor than the other markers that we rely on. So, difficult to diagnose in children early, so we should probably focus on prevention, which is going to be the topic, the focus of both of my talks. So let's talk a little bit about how we prevent renal injury. That same group that I told you about, the kidney disease, improving global outcomes, KDIGO, DIGO group also have a bundle for prevention. And it's a list of interventions that they've studied in adult patients. And these have, they did a multi-center randomized trial using this bundle. And they found that there was a decreased incidence of AKI. So the bundle included optimization of volume status and hemodynamics, avoidance of nephrotoxic drugs, and prevention of hyperglycemia. There is no such interventional trials in pediatrics, in cardiac surgery-associated AKI. There was a meta-analysis based on available observational data, and it didn't identify any effective candidate interventions in children. That is why it's really important that we focus on what we know logically about optimizing kidney function preoperatively, operatively, and postoperatively. So let's go through those three categories and think of practical steps that we can use. So preoperative, we said that volume depletion is a risk, so let's optimize fluid status. Any nephrotoxic drugs, if you can discontinue them or replace them with drugs that aren't nephrotoxic, we should. We should assess baseline renal function so we understand where we're starting. So things like serum creatinine, baseline urine output, and an estimated GFR. Intraoperatively, as much as possible, I'm not a surgeon, and the few times I've watched pediatric cardiac surgery, I don't know how you could possibly rush something that's so delicate. But yeah, I can sit here in the comfort of the ICU and tell you to minimize your cardiac pulmonary bypass time, please, and your ischemia time. Maintain adequate perfusion pressure and hematocrit during the procedure. That's why it's so important that we have anesthetists that are very used to doing cardiac procedures. There is some evidence, although it's mixed, about renal protective agents, which I'll talk about in a second. So for example, aminophylline, there's some evidence that it might increase urine output in the early post-operative period and reduce the need for renal replacement therapy. So there's some studies on that. Same with intraoperative and postoperative nitric oxide. That evidence is mainly in high-risk adults, cardiac surgery patients. It improved both AKI incidence and long-term renal outcomes. Early postoperative Tylenol, acetaminophen, interestingly, it acts as an antioxidant, and it demonstrated significantly reduced odds of developing acute kidney injury in the first 48 hours. So potentially promising renal protective agents. Consider ultrafiltration as well intraoperatively, and then avoiding deep hypothermia. Postoperatively, this is where we tend to come in. And when I was asked to give this talk, I thought in my head, I was like, I don't know, what do I do in the ICU to protect the kidneys? The things I do for any PICU patient even. I do the same things. I avoid nephrotoxic agents. But specific to cardiac patients, all I could think of is low cardiac output syndrome and how scary that is for every organ, particularly an organ that takes 20 to 25% of resting cardiac output.
Dr. Tanya, you have 2 minutes more.
Okay, thank you. I'm just about done. So identify low cardiac output syndrome. We learned all about how to do that. Avoid fluid overload, limit nephrotoxic agents, and try to use renal replacement early in patients that are high risk when, so for example, a patient that has low cardiac output with fluid overload, you need to close the chest, you're trying to get the patient a little drier. Or anytime you have, you need to improve cardiac performance. I'm not going to go through the signs of low cardiac output syndrome because the people who spoke before me did it very eloquently in much more detail, but mixed venous saturations and lactic acid are key. So how do we treat low cardiac output syndrome? Again, my colleagues talked about it already, but I think I would add one drug. I agree. Adrenaline or epinephrine and milrinone, favorite two drugs. But
Calcium.
I would, sorry? Calcium, exactly. I would add calcium to that, especially in neonates. Chronotropic support if you need it, afterload reduction, and mechanical circulatory support, meaning ECMO. Again, all of this has been spoken about before me. So just to conclude, Cardiac surgery-associated AKI is very common and also very serious with both short and long-term complications. Early recognition is challenging, and traditional markers that we use like creatinine and urine output aren't terribly reliable and might lead to underdiagnosis, so consider this furosemide stress test that I mentioned. Further studies on biomarkers are underway. Systematically employ preoperative and intraoperative risk management strategies. So the ones we talked about earlier, they should be applied to all patients, whether they're low or high risk. And then in terms of post-operative strategies, they really center on maintaining organ perfusion and then avoiding any unnecessary insults, for example, with nephrotoxic drugs. So thank you very much. I'm going to move to my
Thank you.
next presentation.
Dr. Ali, I don't know, we have a virtual or we let the Dr. Tanya to continue.
If I don't mind sitting.
Just 1 minute.
But the gentleman online might be waiting. I don't mind sitting and
Yes. No, he's not to me. No.
Okay.
Okay.
So this next one will be shorter, hopefully. But just to say that ICU delirium is incredibly common and very underdiagnosed. It's a neuropsychiatric state of the brain. Thank you. And it could be as a result of
Okay.
it can be as a result of the physical illness itself or our treatment of the physical illness. And in my experience, it's usually our fault. So that's why it's really important that we learn how not to contribute to delirium. I have no conflicts of interest to disclose here either. You're probably feeling quite delirious yourselves at this point, so I'm gonna be involving you more than I did in the last presentation. Stay awake, please. ICU delirium is very, very common. About 50 to 60% of cardiac surgery pediatric patients will experience ICU delirium. It's associated with longer hospital stays, more time on mechanical ventilation, and higher mortality. So it's really important that we try hard to avoid it. It also has longer-term impacts like cognitive reductions in cognitive function and executive function. There are specific risk factors, including prolonged ventilation, children with cyanotic heart disease in particular, and children less than 2 years old, and impaired sleep. But I'll be talking a little bit more about some of the risk factors we're involved in. I want to talk to you about the types of delirium because I feel like, at least for me, for the early stages of my medical career, I considered delirium something very obvious that I recognize. The patient acts combative, they act agitated, therefore they're delirious. I learned later that there are many kinds of delirium, and perhaps one of the more common but difficult to diagnose types are the hypoactive types of delirium. Hyperactive, the child might be agitated or excitable, but in hypoactive delirium, the child might not be interactive, they might be acting very sleepy, they might be comatose. All of these things could also be very serious complications, including strokes or seizures or other alterations of neurologic function. But it's important that we understand that the delirium can also, so you need to think about those things and rule them out, but it's important to understand that delirium can also present as a patient that becomes very hypoactive. They can also alternate between hyperactivity and hypoactivity in these mixed states. It comes on very quickly. It fluctuates its course, so it's very difficult to detect at times. Because it's difficult to detect and it happens very suddenly and it's very common, your best strategy is to do everything possible to prevent it in everybody. Don't wait till you see it. Do everything possible to prevent it in every single patient you care for. Universal prevention measures are extremely important. They should be your standard of care. So essentially, anything I talk about for the rest of the presentation that's non-pharmacological, consider it like the standard of care for all patients. So let's talk about some of the physiological features, some of the pharmacological features, or interventions, I guess, and some of the environmental things that we can do. So for physiologic features, normalizing body functions is very important, making sure the child is getting enough to eat, familiar foods if they're awake, making sure that they're hydrated, making sure that they're not constipated and they're not retaining urine, because children who are unable to articulate those things often become very delirious. So ruling out things like constipation and urinary retention. If you have a urinary catheter in situ, take it out. That's from a tubes and line standpoint, that's the most irritating. Same thing with NGs or anything in the mouth and face area. If you don't need it, take it out. Obviously, I would argue the same thing about central lines and peripheral lines, but often those are difficult to remove. And I'm just reflecting a little bit on one of the lectures I heard earlier. IJs are sort of standard of care for me in neonates now, ultrasound-guided IJs. I don't remember the last time I put in a femoral line for a neonate. And we can start moving towards that, so hopefully we'll be doing a lot more ultrasound guidance going forward here. So normalizing bodily functions. Oops. Promoting and normalizing day and night routines. And I find that this is the one that we're worst at. The ICU always has bright lights. Everybody's chatting at 3 in the morning because it's night shift, and nighttime for me when I'm on night shift is basically daytime for me, but it's still nighttime for our patients. So making sure that we really create regular schedules, daytime schedules and regular nighttime schedules with appropriate lighting for each of those phases. I walk around the ICU in the mornings when I do my rounds, opening all the curtains, saying good morning, and same thing in the evening, close the curtains, turn off the lights, tell them good night, even if they're unconscious. It's just my routine, like really trying to make sure that children are seeing that there are 2 phases to the day. It really helps. And then promoting mobility. Involving physical therapy, involving play, these are things that are so important and we don't think about often when we don't have specialized teams. In the hospitals where I worked at before, we often had child's play, like a special team that comes and plays with the patients. We involved physical therapy very early. If we don't have those teams in the hospitals here, then encourage the family to be doing it. The families are waiting to do anything to help the patient. So instead of having them feed inappropriate foods for the child's arousal status, give them another activity. Pharmacological features, assess your sedation, avoid over-sedation, minimize the use of benzodiazepines and opiates especially. Adequately and assess and address pain. Patients who are in pain that's not being addressed and cannot articulate it are more likely to develop delirium. Avoid polypharmacy, so giving multiple agents when you could do the same thing with a single agent. Monitor and prevent withdrawal, and there's some scores that help us do that. I don't know if those are used here, but they're really useful. Consider melatonin for sleep, and if my patients aren't sleeping, I give them all melatonin. It's a safe drug. I highly recommend always having it around. It's cheap, it's very useful, and it will help prevent withdrawal, delirium. And then, do we have dexmedetomidine in Jordan? Yes? Yeah. Dexmedetomidine, I mean, it has a mixed reputation. I used to work at the Children's Hospital of Philadelphia. We barely used it. I moved to the Hospital for Sick Children in Toronto in Canada, and we use it all the time. I love it. I think it's a very safe drug. The patients stay calm but conscious and relatively pain-free. It's very safe, and it's, compared to any other sedative, it's less likely to cause delirium. So those are sort of some pharmacological considerations. And then there's environmental features. And I don't think we do this very well, and I include myself in this. I think in intensive care in general, we're busy, we're thinking about 1,000 things in the room, there's so much data to look at around us, we're not good at talking to the patients. The parents are nervous, they're asking us a lot of questions, but talk to the child, address them by the name that they go by, speak calmly and clearly, tell them where they are, that they finished surgery, what time of the day it is, reassure them, you're okay, everything's okay, this is what this tube is, this is what that tube is, this is what the plan is for the day, this is who I am. Try and make sure it's the same nurses looking after the patient as much as possible. And explain what you're doing. Like the number of times I walk in on a room of someone putting a urinary catheter in a child who doesn't know what's happening. Can you imagine if you were semi-conscious and someone started putting something into your genitals, what your reaction would be? It's traumatic and in a lot of sense an assault. Manage the physical environment, so noise. This is particularly hard, but we have to be conscious. You know, we live at work, usually in medicine, so it's reasonable that we want to joke and talk to each other about our weekend, but try as much as possible to do that in a soft voice. Cluster care for the patient so that they're only interrupted in limited times. I like creating a familiar environment for my patients, so putting pictures around the bed, their toys, the things that they know, so that it feels a little bit more familiar. The clock and calendar are more for older patients. So, really important that we have universal prevention measures for all patients. But then we also need an identification system so that we know when a patient becomes delirious. I'm just curious, are your patients continuously assessed for delirium in your unit? Do you have like a scoring system that the nurse uses? No.
Our nurses do. And they are very smart in early detection of early delirious signs.
Which scoring system do you use?
I have to go back and ask the nurses.
Okay.
But
So,
I'm sorry, but just they have reported several times that this patient is not acting right.
I suspect, though, if you don't know the scoring system that they use, they don't have a scoring system, they have more of a feeling, and they're good at detecting it with a feeling. When I say a scoring system to continually assess for delirium, remember, hypoactive delirium is very difficult to assess. So there are scoring systems that are like vital signs. So every time the nurse comes and sees the patient, they score them. And there are a couple examples. The validated tools are the CAPD or PCAM ICU. I'm used to the CAPD score, which is the Cornell Assessment Pediatric Delirium Scale. So you have a bunch of questions, and then they rank the patient and they get a final score. And a CAPD score equal to or more than 9 suggests the patient might be delirious, and you really need to go and then assess them to confirm that. When I round on patients, I ask for the CAPD score. And I ask for the CAPD scores overnight because remember we said delirium is a fluctuating state. So maybe in the morning, the patient doesn't seem delirious, but the rest of the time, overnight they were delirious. So it's really important that we use objective tools as well. And for example, a lot of units use this tool and they screen twice a day with a CAPD score. So how do we interpret it? Particularly in developmentally delayed patients, which is often with cardiac surgery, a lot of our patients are syndromic maybe and might have other delays. CAPD score is validated in developmentally delayed children too, but it becomes less specific. It's still pretty sensitive. It's like 96% sensitive, but about 50% specific. That said, developmentally delayed children are 3 times more likely to develop ICU delirium. So even though the test is not very specific, it's still important that we're regularly screening them. You score them the same way you scored children without developmental delay, and you don't need to adjust from the baseline. You just document what you see. And the only difference is if they have a positive CAPD score, it's more important that you really assess them in person and sort of compare how their behavior is now, with the baseline that the parents provided to you. This table was taken directly from the CHOP pathway, which I'm going to show you at the end, the Children's Hospital of Philadelphia, and I'm going to give you the link to it because it's really useful and has some direct links to things that I don't have time to talk to you about in this short presentation. So more than 9 in a developmentally appropriate child, you want to evaluate for other causes of acute agitation or hyperactivity. You don't want the patient to have a more serious abnormality, medical problem that you're not addressing. And then if it's less than 9, just continue your continuous monitoring. It's because the sensitivity is so high, there's a high negative predictive value to a negative result. So common causes of delirium that we need to think about. There's an acronym, again, from the CHOP pathway of things you need to think about in any patient that has delirium. So the acronym is BRAIN MAPS, but essentially B is bring oxygen, R, reduce or remove drugs, A, the atmosphere, I is thinking about infection and inflammation and doing a workup for that, N and M, organ dysfunction and metabolic disturbance. I'll let you sort of go through these in your own time, but it's a really useful acronym to think about differential diagnosis for a child presenting with delirium, because an agitated child may have a more serious underlying clinical condition. Pharmacological management. I hate this slide and I want you to forget it, but I have to present it to you because it's important. Antipsychotics can be used in delirium in children, but there are a lot of caveats, and they should only be considered in exceptional circumstances and after all non-pharmacological interventions have been implemented. We use it as a short-term adjunctive therapy if there's very distressive symptoms, like the child is combative or extremely agitated. If we're using them, we reassess daily and try and stop them as soon as possible. If they've been on them for a while, remember to wean gradually. There are no medications that are approved, for example, by Health Canada, by the Food and Drug Administration in Canada or the US, for the treatment of pediatric delirium. None of them are approved. And there's very limited data that supports their efficacy. I'm still going to talk to you about the drugs, but with the caveat before I talk to you about the drugs that they cause QTC prolongation, they can decrease your seizure threshold, they can cause extrapyramidal syndromes, dystonia, neuromuscular syndrome. So make sure that you get an ECG before you start any of these drugs, and that you do them with each dose increase. So these are the 5 drugs we think about: haloperidol, olanzapine, risperidone, and quetiapine. Haloperidol, because of the IM route option, is often used as a sort of quick combative child. You need to calm him very quickly. But it does have a very high risk of dystonia. I was going to say something else about that. All the dopamine antagonists are on the key potentially inappropriate drugs or kids' pediatric list. So drugs that might be inappropriate in children, there's a list of them, and all of them are on the list, particularly with infants and children because of the risk of acute dystonia. And with intravenous administration, you have an increased risk of respiratory depression and death. With olanzapine, there's a risk of metabolic syndrome in children with long-term use. So if you're using it over time, make sure you're getting a metabolic panel along with it. So which drug would I choose if I had to choose any of these ugly drugs? I would choose quetiapine. So quetiapine is the drug of choice in the treatment of acute delirium in children, at least at Sick Kids in Toronto and Children's Hospital of Philadelphia. And this is the table from the Children's Hospital of Philadelphia guidelines. Again, you see it says preferred agent under quetiapine. Risperidone, they prefer it for autistic children and children less than 7, or autistic children less than 7. Okay, and that's it. This is the QR code if you want to quickly scan to pull up the Children's Hospital of Philadelphia pathway, which is really useful. In fact, CHOP has a lot of public pathways that you can access. Just leave that up for a second. I'll come back to it in a second if you haven't a chance to screen it. So just to conclude, ICU delirium is very common and associated with higher morbidity and mortality in pediatric cardiac surgery patients. Prevention measures should be standardized because it's so difficult to diagnose, and also because we don't like pharmacological measures, so it's environmental measures for all. All patients should be continuously assessed. You can use a tool like the CAPD scoring system. And remember, management is primarily non-pharmacological. We rarely use drugs. If we do, quetiapine is your safest bet. And remember to get an ECG. Thank you very much.
Thank you, Dr. Tanya, for this very interesting talk. Now we open the floor for a few questions. So we have the virtual. Is Dr. Mauro with us? Dr. Mauro, did you hear me? Mute. Unmute. Yes, we can hear you. Okay. Good evening, Dr. Mauro. We invite Dr. Mauro. He will talk about life-saving circuits, post-operative ECMO. You are most welcome to present your talk.
Thank you very much for your kind invitation. I have to now. Okay. So, can you see my presentation?
Yes.
Okay. First of all, it's a great pleasure to be with you. Thank you for your kind invitation. And I apologize not to be here with you, but there are some logistic problems. And I have also to apologize with you because I have some problem with my laptop, so I am not able to move away the Bluetooth windows. So I'm sorry. You will see for the presentation. Anyway, we can start about this interesting topic. We will start about some kind of definition of the ECMO. The classical definition is an extracorporeal circulation and also the loop circuit aimed to support heart or lung growth for mountain and runner. It's important thing that we have to keep in mind is that it's a strategy, it's a technology, but it's not a therapy itself. So the ECMO paradigm is to support the native function parallel, so it does not replace the native function as it happens during cardiopulmonary bypassing cardiac surgery. It provides time to recover organs from an acute or chronic event, but in case of postoperative, it's generally an acute event, and it reduces the native mechanical stress and organ function overload due to the acute event. The postoperative ECMO epidemiology reports an incidence about 2 to 8% of all congenital heart surgery. The configuration renal is the most predominant, generally 85 to 90%, and the neonates and the infants is the highest risk group compared to bigger children and adult children. The typical duration of an ECMO, postoperative ECMO, is from 3 to 7 days, and what is important is that the mortality is quite high mortality, about 45 to 50%. There is a different way to classify an ECMO, by the organ supported, by configuration, by cannulation site. But in any case, when we talk about postoperative ECMO, the most common are the circulatory for the organ supported, the arterial by configuration, and the central or the peripheral, the neck, and the groin, when we classify the ECMO by the cannulation site definition. This is an important point because it's probably the most important point according to the general outcome of the patient. Because if you are wrong indication or wrong indication, this usually impacts the results of your ECMO. The general indication of a postoperative ECMO are cardiogenic shock that are related mainly to postoperative cardiac failure, cardiac arrest, or cardiac arrhythmia, cardiac arrest in the postoperative course. Of course, the failing waiting for cardiopulmonary bypass in the cardiac surgery setting. There are some patients suffer also of acute respiratory distress syndrome in the post-operative course, but in our experience are a very limited population in the pediatric setting. So, according to a general definition of indication, we can say that there is a good indication when we are going to treat patients with a potentially reversible heart and respiratory failure. And when we are in a setting in which we reach the maximum conventional pharmacological and medical treatment. This means that we have to support the patient early but not do too much early. On the opposite, when we talk about contraindication, we have to consider that one obviously a good indication if there is no reversible condition and the patient is not eligible for other forms of support like ventricular assist device or cardiac control and transplant. Obviously, another contraindication is incompatibility with life, even if it can successfully wean the patient from the ECMO, like in a severe brain damage or brain death, and all lethal chromosomal disorders, which have a very poor prognostic in a short to medium term. There is an important relationship between duration, timing, and outcome, and we have, when we face the word of ECMO, you have to take into consideration of this. This is part coming from the class 1 study, and multi-center study, but as we can say in Chile, there is a U-shaped mortality in this position, in which we have the better outcome in the middle part, and the worst outcome in the first 2 days and more than 7 days. This is quite clear because if the patient died in the first 2 days, probably the indication was not so good. So in conclusion, a prolonged ECMO is, we can say, have an increase in the risk of complication, not only survival but also in morbidity. But once the patient is discharged, in general have a good outcome. About survival outcomes, this is a paper, an elegant paper from the group of Crawford. As we said, the survival is about 45 to 50%. We have to realize that 95% of patients, one discharged from a hospital are alive at 1 year, 80% at 5 years, and 82% at 8 years, but it's a conditional survival. Conditional survival according to the patient is still alive. One another thing is very important is that single ventricle physiologist is an independent predictor of death, and that we can find a functional mobility in any way in 40% of patients to far and a follow-up. If we have a look to what the ELSO program report, we can see clearly that there is a better survival in the pediatric population with respect to the neonatal, and the survival is better in cardiomyopathy and myocarditis with respect to congenital defects of cardiac arrest. And consider we are talking about post-operative course, we have to take in mind so that, again, even the ELSO report are around 45 to 55% of survival at the discharge from hospital. So, which are the main predictors of mortality in this very hard to treat population? As the other relatators said before, high pre-implant lactates are one of the most important predictors, as well as pH less than 7.2 or prolonged CVD over the 180 minutes. Another aspect is the late cannulation. That means that we postpone the indication of in the results are in favor of view of not with CPD patient. That means an elective anticipatory really early influx of ECMO, often quite often, obviously in the operative room, that lead to a better outcome in the post-operative course in terms of renal function, but also in the length of stay in the ICU. Another thing, I'm sorry you can see very well, is the pediatric cerebral performance category. That is another aspect because respect to the adult population, in our experience and the follow-up, there is an amelioration, shifting in the better outcome cohort, and this is important because we don't have to be afraid, even in case we experience a even severe neural impairment. The predictors of neural impairment are the heart disease, the presence of events in cannula in the left lateral, in the left ventricle, mainly related to the possibility of embolism. The rapid CO2 drop that move in terms of systemic perfusion due to the CO2 shift that, as we said before, even in the pulmonary reaction and in cerebral circulation, the H-barrier and the presence of the cardiogenic shock state that will improve the out risk of 5 times. How do you manage these adverse possible events? The first thing is to avoid PaO2 and PaO2 change at the cannulation, so that we have to keep deviation not over 20% during the early phase of ECMO. A target map within the age-specific limits in order to preserve the cerebral auto-regulation. Routine monitoring with near-infrared spectroscopy and continuous EEG. There are now new reports of MRI, portable MRI when the patient is stable, and long-term analysis in order to understand which is the neurodevelopmental follow-up at 6 months and longer. Another problem, big problem during the course of ECMO is the renal morbidity that, as the previous speaker underlined, is related to mortality and morbidity. The ECMO incidence during support may rise to 60 to 70%, and in case of this kind of population of patients they can suffer for a previous insult during cardiopulmonary bypass can arrive up to 80%. There is the presence of DMA, particularly in the most complex surgery, it may present up to 28-30%, and is clearly associated to mortality. As well, so stage 3 is almost 4 times increase the risk of mortality. As well, the fluid overload, that particularly in the neonatal population may fluid overload more than 10%, not so much considering the population, is clearly associated with a 2.2 risk of death. So what we can say about the presence of age? That the estimated incidence of achy and severe achy require renal replacement therapy if the patient receives ECMO. This risk of developing use of this support is 60.9 and 40.9% respectively. What is really important is that the presence and development during ECMO of achy is is associated with reduced patient survival. So any efforts has to be done in order to prevent as much as possible the insurgence of this really detrimental pathology. How to manage? The possibility is that bigger children, but even in pediatrics and in neonates, the early use of continuous replacement therapy. The indication, as you said, is that we go below more than 15%. So it's important to estimate the fluid balance in this population. Persistent hyperkalemia or hyperammonia in neonates. The anticoagulation may be done according to the anticoagulation of the ECMO support, generally systemic heparin that is monitored with a activated time or with some other case, but not really in our experience in the smallest patient with regional syndrome. The technique may be different. There are some reports, but in any way, the filter may be put in line in the ECMO circuit, or as we do here in our institution, we use a CRT machine in series with the ECMO filter. The improved fluid balance and the early CRT reduce the mortality, and another thing is important is that we have not be afraid of risk of bleeding because there is no other risk reduction in CRT integration. We have also to consider hepatic dysfunction, particularly in smallest patient, that can lead to hemorrhagic complication or thrombotic events due to the inability of the liver to produce coagulation and anticoagulation factors. So this modifies even the anticoagulation setting that you have to keep during the ECMO support. Remember that the hepatic failure is an extreme risk phenotype, and it's not so, it's quite common to have very high bilirubin level during ECMO support. Bleeding and thrombosis impact usually in the ECMO support. Major bleeding is up to 50%, and the thrombosis of the circuit oxygenated, but I can say even in the heart chamber increase the narrow risk for embolic. The longest ECMO have the highest rate of major non-hemorrhagic lesion, and you should have a close and static monitoring to detect any adverse event. There is not really a consensus in literature about the optimal test. Probably the idea, what the survey guidelines suggest are now the combination of a laboratory test and point-of-care test. A lot of centers, not our center, use anti-DNA with target 0.7 or ACT 108 to 120 and monitoring tag or automatic. This is our approach, considering the use of heparin as anticoagulant and evaluating. Our approach is a multidisciplinary approach, but in any case, the combination of viscoelastic test and point-of-care ACT in order to obtain the most powerful body positive predictive value in order to move the anticoagulation. Anticoagulation is generally done with heparin, but there is too, but also for heparin resistance. Remember that PPI has some limitation, some kind of adverse effect that have to be considered. Just to slide about ethics, because unfortunately this kind of population not always can be achievable, so we can have the needs to withdraw the patient from the ECMO. The withdrawal criteria is when the ECMO is not effective, or anyway the patient was, the situation is so severe that they're not able to ameliorate. And the general stop criteria even on our center is a persistent severe acute brain injury with a poor prognosis or the presence of MOF. Important is to schedule family meetings at fixed interval and document everything in order not to have any kind of problem. Consider also to integrate quality care from the first day in order to be quiet, and even the parents in order to be really transparent with the families and to communicate any answer. There are, this is probably really the last slide, consider future direction. There are some approach that move to a closing-cooperative nerve perfusion monitoring. There are now the possibility to investigate even the micro-circulatory pattern in order to understand if there is hemodynamic incoherence even in this population in ECMO with handheld vital microscopy and early detection with acute brain injury. And just things, again, another important thing is the use of artificial intelligence models for risk prediction and timing decannulation. And so is the reason why we have to do great efforts all together in order to create network of multi-centers trial in order to get as much as data and to learn to leave machine learning, but it should be guided absolutely by clinicians. So in conclusion, ECMO save lives, possibility remains high. Early ECMO indication leads to better outcome. We are talking obviously of intraoperative position of the ECMO, neurological injury, and the presence of acute kidney injury, common predictor of worst outcome, and the early CRRT and neuro monitoring may be an improvement in this sense. Ethical planning of the trial should be routine, and should do a clear defining of success or failure metrics and cannulation in order to understand if you are doing a good job, you are going to do a good job or not. Thank you for your attention.
Thank you very much, Dr. Mauro. Just give me 1 minute to ask the audience if anybody has any question for Dr. Mauro.
Mauro, thank you for a very amazing lecture on ECMO. At your center, do you have an ECMO machine running for emergency patients who need it, or how do you plan the access to ECMO when the patient needs ECMO? Like, is there a machine running all the time, or do you start running the machine when you decide you need an ECMO?
This is a huge difference that makes success from not success. From 2012, we started an ECMO program inside the Policlinico San Donato, and we have from 2018 we have an ECMO unit. This means that we have a group of people dedicated to with at least one ECMO specialist during the day that is dedicated, and we decided to have a West machine already primed for adults and pediatrics. So we have a couple of ECMO always running for pending cases and for our cardiac surgery program, but also from the network of cardiac arrest in which we are involved as a pivotal center in this area. Consider that the difference again is not the machine alone, but is a structured ECMO program. That means that you have to create a program with people, competencies, and applied.
Thank you.
Any question for Dr. Mauro? Dr. Mauro, thank you very much for your participation, and we hope to see you in Jordan.
I hope so. Let's try again.
Have a good night. Any question for Dr. Tanya and Dr. Khalid?
I'm just going to make a few comments actually about post-operative care, intensive care of cardiac patients, since this is a cardiac symposium. So I think the results and the outcome in the cardiac intensive care has improved significantly over the last few years for many reasons. You know, one of them, of course, the excellent outcome from our cardiac surgeons improved significantly, the post-operative care as well, the nursing care and everything. But I think having a dedicated team on call 24/7 in-house, not at home, for these post-operative cardiac patients is essential and important. Not to have somebody in the hospital, I think it's a sin to call the intensivist or whoever from home to come after the patient crashed. Outcome will not be good. So I think this is very important. The other thing that I think probably Mauro touched on briefly, and maybe Khalid and Tanya, is AI. So now many intensive care units in the US, they have a room with all the cardiac monitors of all the patients, and people are observing this, and AI input looking at certain parameters that if such patients develop these things, those are the patients to jump before they get into trouble. So I think this is very important to hopefully when this becomes available in Jordan to implement. And last but not least, I'm going to say this even if they take me and put me in jail. This is the country of Jordan. We have a lot of resources, but it is shame on us that we do not have pediatric ECMO program in the Hashemite Kingdom of Jordan, and maybe have very little for adults. This is a responsibility that starts from the head up down to the Minister of Health and all of us to make sure that we establish pediatric as well as adult ECMO program in the country. This is not acceptable for a country like Jordan with so many bright people and so many resources.
Thank you.
Thank you.
Thank you, Professor Ziad.
May I have one question to Dr. Tanya relating to ultrafiltration, the MUF use. Do you use it, for all your neonatal cardiac surgery as a routine, or you have certain indications? Yes, the MUF.
Honestly, I'm not sure what the surgeons were doing. Generally, it's recommended if able. You have to make sure that you continue to have continuous flow, but I see Layla nodding her head. Do you have an opinion about this?
Yeah.
Muffing?
We do MUF, yeah.
Sam does MUF.
Yes.
All pediatric patients.
Yes, all of them.
Oh,
Muffing of all patients gives better results.
all of them.
Yes, all of them.
This can be a problem because those patients can be dry coming into the ICU because they remove a lot of fluids with MUF.
Yes,
So you have to be careful that they
with the fluid.
hypotensive, so
Yes.
they sometimes need
And
fluids.
concentrated.
So watch your CVP. But Bassam, and I'm not sure because Yusuf has been out only recently. I didn't ask him, but I know for sure Bassam used to do MUF on all patients.
And
Yes.
Yusuf
And,
also.
and this is
he
the
used.
best recommendation. I agree
Yeah.
with Dr. Khaled.
Uh-huh. Yes.
Probably needs some different filters. So it's much more expensive. So I don't think it's done routinely on every patient. So just double check with the surgeon if he does, or the perfusionist, if he does only the hemofiltration or the modified ultrafiltration. They're different.
Yeah.
One other thing, if you don't
It is
mind.
institutional based. Depends on the institution and the whole team. I
Yeah.
personally prefer for
Yeah,
every
you
patient.
prefer it. One more question, comments or so?
Add to what Dr. Ziad Hijazi said, which has been my philosophy cardiac surgery is I've been focusing most of my cardiac surgery in one program, one hospital, one team, because if you dilute the experience of doing small number of cases in so many various hospitals, you dilute your experience and then the outcome is terrible. Please don't misunderstand me. I do most of our cardiac surgery for the past now 15 years on a charity basis, so I don't get paid. However, what I'm trying to say is if you focus all your patients in one institution, your anesthesia become acquainted with, anesthetizing a 2.5 or 3 kilo baby for a switch, and also your perfusionist will get experience. Perfusionist, your ICU team knows how to handle your patients on a frequent basis. So my point is, do not dilute your experience. Focus in one hospital because that can guarantee you a better experience and hopefully better outcome. And I know in the U.S. there's a trend that they're trying to shut down hospitals that they don't do surgeries above. دكتور زياد بده يعلق على الموضوع. أنا بعتقد هي مهمة يا دكتور زياد صح؟ المايك ممكن بس دكتور لأنه بيقولوا I think below 150 or 200 surgeries.
Yeah, I think you're absolutely right, Khalid. I think volume has been proven by many studies to drive outcome. For a country like Jordan with 10 plus million people, obviously one center is impossible. You will not be able to keep up. You have not enough beds. I think for a country like Jordan, probably 3 to 4 centers distributed in different regions is the smart thing to do, and that's how you can train excellent teams, no matter what. But definitely volume is a must. But if you do like 1 or 2 cases a month or 3 cases a month in a hospital, that's not a favor for anybody.
The problem, and I'm coming at this as a socialist, but the problem here is that a lot of the cardiac surgery is concentrated in the Royal Military Services and in the private sector. And ideally what you would have is a university hospital in Amman or somewhere that was open to the public and not just charity programs that are running in the private sector, where you would have trained perfusionists, an entire ECMO team, circuits that are primed, and to do that you need massive volume. And from what I've seen, at least amongst the private hospitals I've visited, there is nowhere near the volume that you would need to set up a safe, effective ECMO program in all of the private hospitals that are doing cardiac surgery. And to do that you would need economic buy-in from the government. You just need these places to be much more funded than they are right now. Jordan University Hospital is not funded enough to have an ICU team that has the skills that you're asking for.
Absolutely, Dr. Tanya. That's why it's a national issue rather than a hospital. Everybody goes to the Medina Tabiya because it's free. Right? So if you make it free at the university hospital or at Hamza or, good centers, then you will have the right number in each center.
Or start the ECMO program bil Medina Tabiya with enough funds. That would be ideal, have it in a public.
Exactly. I think an ECMO program in one hospital may be reasonable, although for 10 plus million people, you're going to have a lot of ECMO. We are in Qatar. My cardiac ICU, this week we have 3 ECMO babies running, 1 diaphragmatic hernia and 2 post-op cardiac. And this is just 2.2 million people in Qatar. So imagine for 10 plus million, you will have much more than this.
Yeah. One more question for Dr. Tanya. Regarding the delirium and ischemic time. You mean above 40 minutes, you notice that they show delirium as ischemic time? It was cut off 40 minutes and above?
I talked about ischemia time for renal injury.
Yes.
So yes, they were talking about risk factors of 90 to 120 minutes, trying to keep it below that time.
Yeah.
You're less like that. I heard delirium, sorry.
Delirium. Delirium, your talk.
For delirium. So the first,
yes.
When I talked about cardiopulmonary bypass times, it was in reference to kidney injury.
Yeah.
For delirium, I assume that if you have brain ischemia, you're more likely to develop delirium, but I don't think I mentioned anything about
just
bypass times. Yeah.
طيب
With that,
خلاص.
Yeah, please. With that, we finish our session. Dr. Ali, please.
شكرا جزيلا يعني خصوصا للي ظلوا حاضرين للآخر. شكرا جزيلا للمتحدثين طبعا قبل ذلك. it was يعني I feel that it was a good day, scientific day with the variety of topics that were discussed of interest for different interests يعني. فشكرا. أنا من الناحية العلمية بحكي والدكتور جمال بده يعطي closing remarks.
Thank you, Ali. Dear colleagues and distinguished guests, as we conclude this remarkable conference, I wish to extend my deepest gratitude to each and every one of you, to our esteemed speakers, moderators, participants, and partners, whose efforts made this conference a true milestone for cardiology in Jordan and the region. Together, we launched the first unified national and Arab protocols for heart failure, atrial fibrillation, and arrhythmias, in collaboration with the American Heart Association, European Society of Cardiology. We did a new setting standard for evidence-based cardiac care. My sincere appreciation goes to the Ministry of Health, our partner institutions, and all members of Jordan Cardiac Society for their dedication and teamwork. Special thanks to Professor Ferrari, a valued supporter and partner, for their role in advancing hands-on training and cardiac education. Let this conference mark not an end, but a beginning, a renewed commitment to science, unity, and service to our patients. And please don't forget our next great milestone awaits American College of Cardiology Middle East 2026, hosted by the Jordan Cardiac Society in Amman, September 30 to October 2nd, in collaboration with the American Heart Association, American College of Cardiology, and the European Heart for Children. We look forward to welcoming you once again here in the heart of the Middle East, here in Amman. Thank you.